Hello, everybody. I'm back. I know you're saying, yay. Let's now move on to coronary cardiac issues. And we begin, of course, with coronary artery disease. I'm not going to do this too much just because I think by now you know, but I think the most important part to realize and to think about and every time you're answering questions is that with coronary artery disease, you have plaque that essentially protrudes into the lumen of the blood vessel, which reduces the amount of blood supply to the coronary tissue, to the cardiac myocyte. And therefore, what you expect or what you have to consider with every cardiac issue is that the demand for oxygen may increase, but the ability of the coronary artery to supply the oxygen of the increased demand is not going to be there. So it's a supply and demand issue. When we talk about cardiac disease, it's really a lot about drugs and what drugs are used to help that patient who has known cardiac disease and of course, which is hypertension is a risk for it, what drugs are used so that this individual does not progress or worsen or to control symptoms. And again, this is the ABCD of cardiac disease treatment, where we talk about A as ACE inhibitors or ARB, angiotensin receptor blockers. And I've given you the list of all of the different things that I think you need to know. Notice that with an ACE inhibitor, there's always a concern with potassium. There's always a concern with what's known as angioedema cough, considered an allergy. And then anytime the patient has hypovolemia or dehydration, then this drug needs to be stopped. We've got a beta blocker, which there's all kinds of different reasons that a beta blocker is used. If you think about you when you go up a flight of stairs, you know that automatically when you increase demand, your heart rate's going to go up. Well, with a beta blocker, these individuals, we don't want their heart rate to go up because we don't want the demand or need for the cardiac myocyte, for the cardiac tissue, to increase because oxygen can't be delivered. So we use the beta blocker so that the patient doesn't get chest pain every time they get up to brush their teeth. When you've got, and I've got that all written here, again, hold for low heart rate, low blood pressure. Calcium channel blockers prevent spasm. And again, you can see what the contraindication is. Dietary, this is lipid-lowering drugs. There's different categories for this. You've got statins, you've got lipid-lowering drugs themselves. Notice that with statins, stop taking if there's muscle pain because there's a rare issue with rhabdomyolysis, which is muscle breakdown. Niacin will cause flushing. So these are just some key things. Again, I know it's overwhelming with the amount of information in this course. You can consider listing the drugs on your exam sheet. When we talk about coronary artery disease, we can talk about chronic stable angina, and that's identified as a patient that will get chest pain every time they get up and climb a flight of stairs, and then that chest pain goes away as soon as they get to rest. But when we talk about acute coronary syndromes, now the pathology of the plaque has actually changed. You had plaque that was in the artery, and that plaque now ruptures. And the rupture of the plaque will stimulate platelet aggregation and thrombus formation, which is a fancy way of saying what once was a plaque problem is now a clot problem, because a clot is formed whenever that plaque ruptures. And whenever the plaque ruptures, you're going to have one of two different scenarios. You're going to either have a partial occlusion of the artery, or you're going to have a total occlusion. Well, how do you know which is which? Well, we know that we got to look at the EKG, because the EKG will guide and tell us what's happening within the heart myocyte. When we have plaque rupture, if that plaque is causing a partial occlusion of the artery, the things that should clue you into that occurring is ST segment depression or T-wave inversion. Again, reassure you that you're not going to have to look at an EKG and diagnose. That's a physician's responsibility. But if you hear these key words, ST segment depression, then you have to think about, all right, that's unstable angina, that's partial coronary artery occlusion. And of course, what makes them have unstable angina is the fact that the chest pain would begin either at night while they're at rest. And that's what usually their signs and symptoms are. When we talk about, again, acute coronary syndrome, that's plaque rupture. The other scenario could be that the plaque rupture caused a total occlusion. And the key words that would clue you into this as total occlusion is ST segment elevation. Now, you know that there's always some exceptions, but again, you're just going to have the black and white on this EKG sound. So ST elevation, until proven otherwise, you have to think that you have a total occlusion. What is the treatment for anyone with acute coronary syndrome? In other words, unstable angina or an acute myocardial infarction. We do put them on bed rest so that we reduce their oxygen demand, and then we institute or deploy the MONA. That's the administration of treatments whenever an individual comes in with an suspected acute coronary syndrome. And just to remind you, MONA is a cute little naming of all the treatments, but it doesn't necessarily mean that that's the order in which you deliver these medications. You know that likely you're going to give oxygen and aspirin in the very initial contact with the patient. And I've put the information on each one of these things on how they help in this scenario. And we know that patients usually that are having chest pain will start with nitroglycerin, and then once 3 nitroglycerin have been given, then we're going to move on to morphine. And morphine has another effect in that it will reduce anxiety and can maybe stop that increased heart rate if the patient's not as anxious, and therefore that will also decrease demand. So be sure and read through these because it is likely you'll be asked about this at some point in the rest of your testing career. When we talk about coronary artery disease and anything to do with acute coronary syndrome and acute myocardial infarction, please note that dysrhythmias are the most common problem. And as we talk further about different cardiac issues, truly, whenever you think about heart, think that the most common problems are going to be dysrhythmias. Common problems are going to be something simple. They are called common because we see them quite often. Anytime there's a coronary artery disease, if we go back to this picture here that's up on the top right hand corner, you can see that the treatment for all things coronary occlusion are going to be angioplasty. Yes, the patient may need bypass, or they may get TPA. Those are options, but probably the gold standard for treatment for coronary occlusion is angioplasty. If you don't remember the problems with angioplasty or the details about it, then go back to the CAD so that you can see the different links that I have that can show you the cath. Notice that the most common complication of a cardiac cath is post-cath bleeding, and that's because these patients have been given drugs in IV for thrombin inhibitors because, again, we said it's a plaque problem, but after rupture, it's now a clot problem. So we have to give them all these drugs so that we stop the whole clot problem. And so that's why they get aspirin, oral antiplatelet drugs such as clopidogrel or Pavix, and then you also have given heparin or some other drugs that are thrombin inhibitors. So that's why you have post-cath bleeding. So you need to always be aware that that's a complication. Remember that if a stent is placed and then the stent suddenly occludes and you get ST elevation, that means the artery is occluded again. Again, ST elevation, always, 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 no matter what the scenario is, think of a total artery occlusion, coronary artery occlusion. Some other not as common problems or complications with an acute MI are listed here. One of the things that can occur is pericarditis, and I put this in here because whether you're asked or not, students always confuse signs and symptoms listed with between pericarditis and cardiac tamponade. Again, pericarditis is going to occur 2 to 3 days after an MI, and there is fluid in the sac. You may have low blood pressure, but the key things that are going to be there that are going to signal pericarditis is that the patient has chest pain and that it's aggravated on a deep breath or with movement or coughing, and that the chest pain is relieved by sitting forward. If the nurse auscultates, they may hear a friction rub, and again, the treatment, because it's an inflammatory process, is going to be NSAIDs or aspirin. And we've got Dressler syndrome, which is a little bit different than pericarditis, but it kind of would link to the same as far as the signs and symptoms go. Keep that in the back of your head. Do not get confused between pericarditis and cardiac tamponade. Moving on to cardiac surgery, already I did make the statement that let's say you have a patient that comes in with chest pain at rest. We do a 12-lead EKG. They have ST elevation. We think they have a myocardial infarction, or we determine they have a myocardial infarction because of the ST elevation. The patient is sent to the cardiac cath lab, and the patient has a lot of blockages. And the cardiologist says, you know what, I am not going to be able to fix this problem with angioplasty. This patient needs to go for cardiovascular surgery. They need to go for bypass surgery. And again, then you're going to be asked, well, tell me about what happens after you have bypass surgery. And again, the complications are related to being on the bypass machine. And I'm going to have you read that because I don't want to go through again and beat the same drum of this information over and over, especially if you know it. Just read the slide and realize that anytime a patient is cooled, which is what the heart is done during bypass because they don't want it beating while they're working on it, these patients can develop hypothermia. If hypothermia occurs, they will have vasoconstriction because that's what happens to your blood vessels whenever your temperature is lower than normal. Patients will have vasoconstriction. We monitor fluid and electrolyte status, and then of course we have to assess for bleeding. Notice these chest tubes that are placed in. And there can be anywhere from 2 chest tubes in the mediastinal area, that's in this space right here where the heart occupies, and then there are some thoracic or pleural chest tubes also. And you would expect a total of about 100 to 200 mils per hour initially from all tubes, not from each one, but from all tubes. Therefore, if you have a scenario where you're given and you've got a patient that has a mediastinal chest tube, and there's either no drainage for it or a minimal drainage from these mediastinal fluids, that you always have to be on the lookout for cardiac tamponade. We've already talked about this, but again, I think it's important enough to remember that you have Beck's triad is an indicator of cardiac tamponade, and the 3 things are increased CVP, JVD, narrowed pulse pressure, muffled distant heart sounds. That sounds like more than 3 signs and symptoms, but I guess they kind of shove all of these together. Well, Beck's triad, cardiac tamponade, that is when that drainage becomes occluded and you've got nothing coming out, and because of all that fluid that surrounds the heart in this space, the heart can't pump, cardiac output goes down. Now on the flip side of that, because bleeding is a complication, if you have a whole lot of blood coming out, especially if it's bright red, then you always have to think about the fact that maybe there is some abnormal bleeding going on, and that would be something you would want to report. Postoperative, post-CABG, anything cardiac, consider that dysrhythmias are going to be common, AFib being the most common dysrhythmia, but any dysrhythmia can occur. We have epicardial pacing wires, that's the picture here. Epicardial is the outer layer of the heart. Notice these wires will exit the chest and then they can hook them up to a pacemaker. Again, the only time you're going to see epicardial pacing wires is if we've sawed through the breastbone and opened up the chest. So that's going to be with open chest surgery on a valve or coronary artery bypass grafting. Moving on to heart failure. What is the definition of heart failure? And that's the inability of the heart, either the left ventricle or the right ventricle or both, to pump blood forward. And if you recall from your other courses that you've taken, we kind of divide things into left-sided signs and symptoms and right-sided signs and symptoms, though the patient may have both. I'll let you look through those if you cannot remember the signs and symptoms. But most of the time, and especially in this course, we really just talk about the generic heart failure. We don't divide it into right and left. I don't know if Hesse will do that, but you just need to be aware that heart failure can be right and left, or it can be just labeled heart failure, which is just kind of the generic term that the whole thing, the whole heart's not working. What would indicate heart failure? Your serum BNP, B-type natriuretic peptide, will measure whether that patient is in heart failure. Again, read this slide. Link troponin with myocyte infarction or death, and then link BNP, B-type natriuretic peptide, with heart failure. The higher the number, the worse the heart failure. What's the pathophysiology of heart failure? Well, something causes the heart not to pump well. And that something can be a whole lot of different things. It can be valve issues, or just lots of coronary artery disease, and so the heart's had a lot of ischemia that's occurred. It can be long-term hypertension, where the heart's had to work and push out blood against a very increased systemic vascular resistance. And so over time, the muscle can become weak. Regardless of what the thing is that causes the heart to pump weakly, the cardiac output's going to go down. It doesn't matter what it is. The cardiac output's going to go down when the heart's not pumping. And that's going to cause those kidneys to gripe and complain. And when they gripe and complain, they activate the sympathetic nervous system and the renin-angiotensin-aldosterone system. And because of those things, the RAS and the sympathetic nervous system that becomes activated, this essentially says to the heart that you have to work harder, and that makes the heart even weaker. So the cycle continues. Well, we've got to break that cycle. We have to inhibit the RAS and sympathetic nervous system, and it is for that reason that these patients are on a beta blocker, ACE inhibitor, or an ARB. They'll be on some kind of vasodilator. They may be on aldactone. Again, I have all of those drugs listed somewhere throughout this presentation. You want to make sure that you know what are the contraindications, because that's likely what you're going to be asked about. And here is the other slide that kind of lists what happens with the different drugs. This is just kind of an additional one to that other 4-quad thing on the ABCD that I gave you. So this is just more drug listings. Notice that I put spironolactone here because I didn't list it before. It doesn't fall in the ABC category. And then I've got some other things that are listed there. Again, I'm just not sure what you're going to be asked, so we just like to cover everything. Yeah, brain overload. Then we talk about cardiac rehab, and I really think, again, this is another one of those topics that you've had beaten into your brain over several different years through several different courses. This is just kind of a reminder slide, just to kind of put it back in the forefront of your brain about what things we need to do as far as teaching goes for the cardiac patient. Let's talk about an individual who has either heart failure or has had post-coronary artery bypass grafting, or even an MI. We need to be sure and let them know, well, what are the things that you should notify your doctor? And the big thing is edema and weight gain. In other words, get up in the morning, go pee, and then step on the scale. And if you gain weight, then that's something that you need to contact your physician with. Some physicians have a standing order on the patient that, well, increase your diuretic if you have this. Signs and symptoms of infection. If a patient has had bypass surgery, they're going to have perhaps the saphenous vein removed from their leg, and so they'll have an incision on the leg, and therefore always, always, always with any kind of surgery, we've got to consider infection. And then they should seek emergency care with chest pain and shortness of breath. This is the target heart rate calculator. I wonder why I thought to put this in. You might want to know it. Now we move on to pacemakers. Oh, all right. Pacemakers. What does the pacemaker do? Well, the pacemaker, if you recall, normal cardiac rhythms begins with an electrical impulse, and then uh, the heart responds. It listens to the electrical impulse and responds, and it beats. So you have electrical stimulus, then the heart beats. That's what the pacemakers do. Pacemakers pace the heart. There may be a question on an ICD, internal or implantable cardioverter defibrillator. Remember that ICD offers pacing and internal cardioversion. This is internal shocking. And the most of the time, it's going to be for a rhythm such as VTach or VFib. So if in a scenario you get, oh, the ICD has gone off, has shocked the patient 2 or 3 times, consider that's going to be problematic because your patients had VTach or VFib, and so that's a priority situation. So that's just your reminder of the difference between the ICD versus the pacemaker. Here's some information about ICDs. Again, history of survival from VTach, VFib, that's why one's put in, or the ejection fraction is less than 35%. I don't know that you'll be asked this information, but we just don't pop this $50,000 device into everybody. There has to be some criteria, but it's basically for increased survivability with chronic problems. When we talk about pacemaker management, we're going back to the electrical impulse that is generated so that the heart will then will have depolarization and repolarization. 3 problems that can occur with all pacemakers, whether they're transcutaneous, transvenous, or epicardial, and that's failure to pace. Notice the key terms, because you're not going to have to look at a strip and go, oh, what is this problem? You're going to get key terms. So if the problem is failure to pace, there are going to be no spikes, and the patient's going to have a bradycardia. In other words, the rate is going to be less than what the pacemaker setting is set at. In other words, if you had a patient that had bradycardia, the physician inserted a temporary pacer, transvenous temporary pacer, or you applied transcutaneous pacing pads, and you set the pacing rate as 60. The pacemaker will not pace if the patient's intrinsic, meaning their own heart rate, is 61 or above. The pacemaker is going to pace when the patient's heart fails to initiate a beat of 60 or it falls below 60. That's when the pacemaker will pace. The pacemaker, you the nurse, know that the pacemaker has paced when you see a spike. And when you have a rate that's around 30, and you have this patient with a pacemaker, and the rate on the screen is 30, and you have the pacemaker set at 60, then you know that the pacer has failed to pace. You're going to be asked, well, what's the treatment for it? What does the nurse do when there is failure to pace? And I have the laundry list here. So be sure and read that, because it may be something that you'll be asked about. The other thing that can occur in pacemaker manages is failure to capture. What are the terms going to be on the wording going to be on the test? Well, you're going to have a spike, meaning the pacemaker fired, but the spike is not going to be closely followed by a QRS. So when you look at this beat here, you see a spike followed by a QRS. That means pacemaker fired, the heart muscle listened and then responded by generating an electrical impulse, by depolarizing. That's what that QRS complex is. All right, fantastic. But here we have a pacing spike, but then a flat line. That is failure to capture. Pacing spike, the pacemaker fired, flat line, failure to capture. Here we have pacing spike and followed by a QRS. That's capture. So failure to capture is spikes will not be closely followed by a QRS complex. Notice that there are several things that the nurse can do. They can move the patient's arm, turn on side, in case the wire has been displaced, or the most common treatment or fix for this is to increase the milliamps. And that is the impulse that is generated by the pacemaker. For instance, if the milliamp setting was at 5, you would want to increase the milliamps to 7 or 10. You're not going to be asked a value. You just need to know that you need to increase the amperage, the stimulus, because the heart, like anybody, as I talk and talk and talk, at some point you're going to tune me out. And so you should. And with the same thing with the heart will hear or should listen to the pacemaker firing, but over time, over a day, an hour, a week, who knows, over time, the heart will stop listening, and therefore we need to talk louder. So we need to turn up the volume on the amperage. That's kind of the scenario that I'm trying to get you to get. All right, next thing with our pacemaker management is we can have failure to sense. And failure to sense occurs when the spikes occur when they should not. I say, when there are spikes willy-nilly all over the strip, that is failure to sense. So how would the wording be on the test? Well, it would say spikes occur when they should not. Spikes occur without consideration for the intrinsic heart rate of the patient or the patient's intrinsic heart rate. Something along those lines should clue you in that this is failure to sense. Again, here's the treatment. Notice what could be the danger with failure to sense is that if the pacemaker fires on the T wave, which we don't see here, but if the pacemaker fired right square on the T wave, you have now stimulated the heart when the heart is resting. Again, remember that the T wave is depolarization. Excuse me. The T wave is repolarization. Repolarization. Resting. The heart is resting. And just like you would be annoyed if somebody asked you to go to work when you were resting, so too is the heart. The heart will get annoyed if the pacemaker fires on top of the T wave. And by annoyed, I mean the patient may go into VFib or VTAC. So again, this is very important with failure to sense that we want those spikes to not only fire, but we want that pacemaker to fire when it's supposed to. Pause, take a break, and then let's move on to part 2B.